For patients who are ineligible for transplant, generally speaking, again, a triplet regimen tends to be preferred today. The same regimen we use in younger patients, or VRD, which is bortezomib, lenalidomide, dexamethasone, can be commonly employed at lower doses, something we call VRD light, in which we would use subcutaneous weekly bortezomib. We would use a lower dose of lenalidomide, probably 15 milligrams, and particularly importantly, we would reduce the dose of dexamethasone to 20 milligrams once weekly. Alternatively, the combination of lenalidomide and dexamethasone alone, particularly for elderly patients who can't travel easily to the center for injection, would be acceptable. Increasingly, however, and as we'll discuss shortly, the introduction of the monoclonal antibody targeting CD38, daratumumab, has now been approved as an option in two different circumstances, particularly in the non-transplant eligible patient. Some of the decision factors that go into selecting a therapy for a transplant-ineligible patient include distance from the treating center, the ease by which the patient can come to the treatment center, do they have transportation, are there family members that can accompany them, is parking an issue, is mobility of the patient an issue to actually come physically into the treatment center to receive either an intravenous or a subcutaneous injection. That becomes one of the dominant factors in choosing a therapy in a more elderly, more frail patient. In addition to that, we have to look at things like renal function, because there are certain suggestions that using lenalidomide in a patient with poor renal function may not be advisable. We have to look at pre-existing conditions like diabetes or presence of peripheral neuropathy, which might lean against the use of bortezomib. So many of the factors we use both in the young become important in selecting the initial treatment, but I think the addition of frailty, mobility, and family support become increasingly important as patients get older. For patients who are transplant ineligible today, although the use of VRD light or lenalidomide dexamethasone is very acceptable, people have become quite excited about the potential for using the monoclonal antibody daratumumab, or Darzalex, in this patient population. Two large phase 3 clinical trials have recently addressed the use of daratumumab as a frontline therapy in a non-transplant eligible population. The rationale for using a monoclonal antibody in this setting, of course, is it brings a new biologic partner to the drugs that we already have. There are multiple mechanisms of action of the monoclonal antibody daratumumab. It's not really clear which is most important, but what we do know is as a single agent and in combination with other drugs, it is very active. It can be combined quite easily, and most importantly, particularly in the more elderly patient, is really quite a benign toxicity profile, and we'll talk a little bit about what some of the issues are, but overall it's a very well tolerated drug.